Hi, everyone. Welcome to Grand Rounds. We'll get started in just a minute. Just give people a moment to log on. Okay, well, we are going to go ahead and get started. Again, welcome to the Division of Rheumatology Grand Rounds. Thank you for joining us. Just a couple notes is that Dr. Wundes is going to save about 10 to 15 minutes at the end of her lecture for questions. Any questions that you have throughout her presentation, please feel free to drop those into the Q&A box, and she will field them at the end. And this session is being recorded, and we can share the recording after for anyone who has to drop off or isn't able to attend. So now I'm going to pass things off to Dr. Michael Richter.
Thanks. It's an honor to be presenting Dr. Wundes to our department. She is an associate professor here at the University of Washington, as well as the medical director of neurology and the director of our multiple sclerosis center at Northwest Hospital. She did medical school and residency in Dusseldorf and Cologne, Germany, before coming to the US for a fellowship in MS here at UW, and she's been on our faculty ever since. She has won numerous awards for clinical excellence and mentorship, both from within the UW and from the National Multiple Sclerosis Society, a group for which she serves on the board of trustees. And she's deeply involved in the local MS community as an organizer, patient advocate, public educator. In addition to that, she's also an avid researcher, and her research advances care for MS in multiple ways. One, through clinical trials. She's published phase 3 trials of targeted therapeutics, as well as trials on bone marrow transplantation. And she's also published clinical studies focused on quality of care, women's health, as well as the social and economic impact of multiple sclerosis. And I've also heard from some neurology trainees that clinically she has a special interest and expertise in identifying mimics of MS, which I'm sure is something we as rheumatologists can all identify with. So thank you for being here, Dr. Wundes, and I look forward to your talk.
Thank you so much for this warm welcome, and thank you everyone for attending. So I was tasked with giving you a clinical didactic on NMO, and that seemed to be a more newer format for you. So I hope I meet the expectations. My disclosures are here. And I would like to jump in right away. And because it's a clinical didactic, I thought I'll share a complex case I'm sharing with Dr. Thomason to give you a clinical flavor and an example of a patient with complicated health. This is an African-American female who, until the age of 29, was in good health. She had 2 children, actually were trying to get pregnant again. And she had some mild pre-existing symptoms in form of some malar rush and some joint pains, some unintentional weight loss prior to her severe neurological presentation. Her story starts roughly 10 years ago in 2010, with the first ever neurological episode. She presented to an emergency room because of urinary retention, and while being in the emergency room, she actually developed new weakness in her left leg. They kept her overnight, and the next morning she had weakness in both legs. That was in a peripheral hospital. She was then urgently transferred to Harborview, and in the end was hospitalized here for 2 months. In her initial workup, her brain MRI was normal, but she had significant abnormality throughout her spine, a very large lesion extending from C4, which is basically where your chin is, down to the tip of the spinal cord. And she was treated with 5 days of steroids. She received, because of poor recovery, plasmapheresis, and her stay included an inpatient rehab stay. She was discharged into a rehab SNF where she was the youngest patient at the facility. She remained since that episode, for all intents and purposes, non-ambulatory. At the time of her discharge, she was able to transfer with a sliding board. She had difficulty to maneuver a manual wheelchair because of weakness in her arms, where she had some residual function, but not consistent enough and not strong enough to maneuver a manual wheelchair. She was suffering from spasticity and neuropathic pain, for which she got symptom management. And in the end, she was never able to live independently again. For a while, she was living with her family until her health further deteriorated. So back in 2010, with this very severe episode, she was diagnosed with Neuromyelitis Optica. And I'm now realizing that I should have been more precise here. It's actually Neuromyelitis Optica spectrum's disease. And at the end of the session, you may understand why that was not the full-fledged of NMO at that point. And she had also additional a number of abnormal on laboratory testing, a number of autoimmune disease markers, but was not diagnosed with a specific autoimmune disease other than NMO at that time. Sometime later, however, then it was felt that indeed she does have seropositive rheumatoid arthritis, and her health in the next few years was deteriorated. In around 2014, she was several times hospitalized with failure to thrive and altered mental state, and was diagnosed to have kidney disease, which by biopsy turned out then to be focal segmental glomerulonecrosis. In 2014, 2015 was a very difficult year for her. She was multiple times with severe illness in the hospital. She developed what is called PRES, so that's circulatory difficulties in the posterior parts of the brain, which can happen in the setting of autoimmune disease. In that setting, she developed a new seizure disorder, and in the following year was multiple times hospitalized because of difficult to control seizures. She also developed in that setting cortical blindness because of occipital strokes, and had hearing loss, presumably also because of central etiology. So communication was very, very difficult with her because she had she was legally blind, had some residual visual capacity, and communication was also very difficult because she had the significant hearing loss. Basically, her family could communicate with her the best when she was visiting Dr. Thomason and myself. We had basically her mom as her translator, and then there was a very superficial history and communication possible with the patient. She also had refractory encephalopathy. And in the last year, she unfortunately then died of COVID disease while being immune compromised because of being on rituximab. So this is obviously an example of a very sick patient where we have the comorbidity of neuromyelitis optica and autoimmune disease. And so this is an example of the severity of this condition. And we have also learning from her the association with NMO and your specialty, where there's other clinical findings or laboratory findings consistent with other autoimmune disease. So this was the entry for our discussion and our didactics here today. So Neuromyelitis optica is an inflammatory disorder of the central nervous system, which predominantly affects the optic nerves and the spinal cord, and is characterized by severe demyelination and axonal loss. It's a fairly rare disease, so we estimate that we have around 5,000 to 8,000 patients living with NMO in the United States. And you may think about multiple sclerosis as one of the more common CNS demyelinating disease, the prototype, and that would be it is a condition where we have 1 million people of MS living in the United States, and which is a disease primarily affecting Caucasians. NMO, in contrast, is significantly less common and also has a strong predominance of other ethnic groups. There's also a strong predominance of females by a ratio from almost 9 to 1. And as I said already, many have clinical signs or positive serological findings for systemic autoimmune disease. So we talked about transverse myelitis and optic neuritis as being key factors of this condition. Let me introduce these two terms and their clinical presentations to you. Transverse myelitis can be complete or incomplete, which what we mean with that, if you have an inflammatory process within the spinal cord, if it would be complete, basically from there downward, you would have a paralysis, no motor function, no sensory function. So it would present with what we call a sensory level, and loss of bladder and bowel control. And as you may envision, if it's an incomplete presentation, there may be some residual function in any of these systems. Some patients may present with a sensory level only without any motor or bladder dysfunction. Optic neuritis is when there is an inflammatory attack on the optic nerves, which can present on one eye or both eyes at the same time, presents with vision loss, and the severity of the vision loss can be very different from one person to the other person. Then one very classical feature is that there's eye pain with movements of the eyes. These two conditions are by no means specific for NMO. They can also occur idiopathically or in the setting of MS, what we call anti-MOG disease, I come back to that, and systemic autoimmune disease. In the setting of NMO, however, there are some specific features to their clinical and MRI presentations. I will now try to attempt to give you 150 years of research in 3 slides. Back in around 1819, it was that this neurologist described the first clinical cases as well as autopsy reports on what was then thereafter named after him for roughly 100 years was the name under Devick's disease. And it was described at that time as a monophasic disorder where you have bilateral optic neuritis and severe transverse myelitis at the same time or very, very close to each other. Over the next 100 years, however, it was noted that optic neuritis and transverse myelitis can occur in isolation from each other. That optic neuritis in one eye is actually way more common than having optic neuritis at the same time in both eyes. And that most patients actually present with a relapsing pattern rather than a monophasic disease. And so that then brought us to think about, is NMO a subset of patients with MS? or is this a distinctly different condition? And through observation, it was identified as a subset or a cohort of patients which have some specific features. Their relapses are significantly more severe and are characterized by very poor recovery. So that can be severe optic neuritis leading to blindness, or severe transverse myelitis with poor recovery, as we have seen in our index case at the beginning of this introduction of this didactic. And then the MRI features are also specific and different than in MS. The brain MRI is usually normal at onset, and that was part of some diagnostic criteria at the beginning. And then the transverse myelitis is typically very large, so that's what we term a longitudinal extensive lesion, which goes over 3 vertebral segments. So 100 years after the initial description, then we had the first set of new clinical diagnostic criteria summarizing these clinical and MRI findings. And then just a few years later, the so initially called NMO antibody, and casually we often refer to it like that nowadays still, that was initially identified in 2004. And it was pretty promptly then noted that this targets the aquaporin 4, and which is an abundant water channel in the CNS, the most abundant water channel. And that led then within a few years to the revision of the NMO diagnostic criteria in 2006, incorporating the antibody finding. And from there on, we have taken now a journey of better understanding this condition, better understanding which patients who have this antibody, which spectrums of clinical presentation they represent, and has also helped us in better understanding the underlying disease processes and moving forward, developing targeted therapies. The antibody is targeted against aquaporin 4, a water channel, which is particularly dense in some, let me see if that works, in some parts of the brain, in particular parts of the brain which are associated with the blood-brain barrier, and is particularly present at the astrocytic foot processes along the blood-brain barrier. And the antibodies then, here in this pathological schematic as illustrated here, then you have a deposition of antibodies as well as complement activation, triggering a cascade of different immune processes, which I will not go in great detail in this portion here. And that led then to our understanding that the primary target is this antibody, and the primary disease is an CNS channelopathy, and that the effects on the myelin is to bystander injury to the oligodendrocytes, which are the cells which are building the myelin in the central nervous system, and the axons itself. On pathology, you will see extensive demyelination and an extensive area of axonal injury and necrosis. There's clearly on immune staining, you'll see different immune cells being involved, and there's evidence of the complement activation in a typical so-called rosette and rim pattern. So with this better understanding of the patient population we're talking about, we also have identified their clinical features in greater detail. We already know about the involvement of the optic nerves, which can be unilateral or bilateral, and it's much more severe than in MS. So often enough, patients may have full blindness or less than finger count. So when you're showing the finger, the patient would not be able to see that, or they may not see the shape of a person or some furniture in the room. There are also some red flags on MRI that we see the involvement of the chiasma. So it's not only the optic nerves, but then the extension of the optic nerves into the brain, which are affected as well. And then our ophthalmologists have some additional clinical features, such as hemorrhagic findings, which you would not see in other forms of optic neuritis. We talked about the transverse myelitis, usually severe, and at least on my screen actually doesn't come out as nicely as I had this on my home screen. So a large lesion here, I'm circling it for you. So this obviously vertebrae, disc, vertebrae, and then the gray band here is the spinal cord. The white around here would be the spinal fluid. And in this gray band, you have this whitish cloud, the transverse myelitis. What is noted that almost a quarter or a third of the patient will have the extension of the spinal cord lesion into the brain stem. And that's maybe showing here a little bit better, at least on my screen, where you see this white cloud extending into the brain stem. Those that can be even already at initial presentation and can be so severe that this may cause respiratory failure or death during an acute episode. Another clinical feature which was identified as a so-called area prostrema syndrome that is clinically very impressive, with intractable, prolonged episodes of days and weeks of intractable vomiting or hiccups. And it also has some characteristic MRI features that you'll see here, a cloud in the posterior part of the brainstem, or the connection with the spinal cord. In terms of prognosis and clinical course, patients have, the vast majority of patients have a relapsing course and are actually at risk of another episode in near future after initial presentation. So 60% will have another episode in the first year, and overall 90% of patients will have further relapses in the next 5 years. As already mentioned, the individual episodes are severe and have poor recovery. With that, in a cohort of NMO patients, you will find that around half of the patient will be blind in one or both eyes, or will need an ambulatory device within 5 years of onset of their disease. And if you have a cohort of NMO patient with relapsing course, you will find that more than half of the patients are blind in one eye. And then again, roughly 20–25% of patients will have involvement of the medulla, including, which can be as severe as respiratory failure. Then one of the key features of this disease, and the take-home message, is that permanent disability is relapse related. What we mean with that is that every single relapse carries the risk of life-changing disability or even death, which is very different than in MS. In MS, we have episodes and relapses as well, but usually they're not as severe. They usually have some better recovery, and you may have some stepwise accumulation of disability with repeated relapses, which leave their marks, or more severe disabilities actually associated with later stages of the disease, characterized by neurodegenerative changes, of which we see not too much in NMO disease. And then there is, even though the first set of clinical diagnostic criteria in the 1990s also said that the brain MRI needs to be negative, so a clean MRI and no involvement of the brain. Certain features of certain portions of the brain are actually identified now, and that can cause some encephalopathy, can cause some cognitive dysfunction, and there are certain features of the MRI which points towards a more NMO-specific MRI features. We mentioned already the coexisting of positive serological findings or also clinical features of other systemic autoimmune disease. So this is these are two studies actually which describe that, a little bit older studies, but just to give you an idea. And in this somewhat older literature, the one thing I wanted to point out is that in NMO patients in the cohort at that time, the positivity rate of the serum testing was stated at roughly 2/3 of patients being aquaporin antibody positive, was roughly 1/3 being negative. These numbers have increased over time with advances in the testing. Then you obviously see otherwise that there's kind of a high percentage of patients being positive, having positive ANA testing, and as listed here, other systemic markers. In terms of autoimmune disorders, thyroid dysfunction, autoimmune thyroid dysfunction is the most common clinical presentation. The lower panel is possibly more geared towards my colleagues in neurology, to alert them that there's an overrepresentation of myasthenia gravis as well, higher than you would think in a general population cohort, and that there also can be asymptomatic positivity of correlated autoimmune markers. This is a more recent publication on the same topic, bringing us again, telling us that roughly half of the patients will have at least one or more autoantibodies being serological positive findings. That roughly a third of NMO patients do have clinical symptoms associated with other autoimmune disease, most commonly thyroid disease, and then again that myasthenia gravis is more prevalent in NMO cohorts with some specific features, having early onset, a predominance of females, as well as typically a milder course of disease. With all this advanced understanding, then in 2015, the diagnostic criteria were revised, and these are the diagnostic criteria which we are carrying to date with all the advances in our knowledge. And you'll see that we'll have dividing our cohort now in aquaporin 4, that's a tongue twister if you say that too many times, antibody positive or antibody negative patients. And there were 6 core clinical criteria being identified. Already the first 3 of which, optic neuritis, longitudinal extensive transverse myelitis, and area postrema being the most important ones. If somebody has a single episode and has one of these core clinical features, so an episode of one of these conditions, and is found to be antibody positive, then we diagnose them with NMO in that setting. If the antibody is negative, then we're basically requiring more clinical or MRI evidence for the before we would diagnose somebody with definite NMO in that setting. And the requirement asks that you have at least 2 of these core clinical criteria, clinical core criteria, one of which needs to be the most having one of the most common ones, so the first three listed here, and then what we term dissemination in space, meaning one other area needs to be affected as well, such as the optic neuritis and an area post-tumor syndrome, with clinical features and MRI features classical for NMO, even though the antibody is negative. Some clinical pearls in regarding, given now that the antibody has such an impact also on when we would confirm a diagnosis, some clinical pearls on the testing methodology as well as the timing of the testing. So this antibody testing is actually superior in in serum testing other than CSF. There's many times I'm being called from a hospital, oh, we were not thinking about that at that time, we tapped them. Do we have to retap again? The answer is no. You just sent a serum testing. And then the most sensitive test and what we would call the golden standard at this point is a cell-based test, which has between 75 to 80% sensitivity and a near 100, so 98% specificity. In patients who present as severely as our index case at the present beginning of our didactic here today, patients often get aggressive treatment for their relapse, and it's worthwhile to note that that can interfere with the sensitivity of the testing. So the testing will be less sensitive if serum samples are being sent after steroids or after plasmapheresis, and that may require, that may be indicated to retest a few months down the road. What's about this cohort of patients who are antibody negative? So this is around now 80% of the patients who are diagnosed with NMO or NMO spectrum's disease. And of these 20%, around 10 to 40% are now found to have another antibody, the so-called anti-MOC antibody. There are some overlap in clinical presentation between MS, NMO, and anti-MOC disease. Basically, optic neuritis, transverse myelitis is a common theme in all three conditions. But there are also distinctly differences between these three conditions. MOC antibody disease is a newer entity for us, and we are still trying to better understand the exact spectrum of presentation. One of the things which is probably the common theme is that it's a very broad and wide clinical spectrum of presentation. It can be monophasic, it can be relapsing, and also the clinical features itself and the severity are not so well understood yet. One of the features, however, which seem to be a common theme, is that the acute relapse also can be very severe, often also these longitudinal extensive lesions like we had with our index case, but then very good recovery with giving a few days of steroids. And then frequent patients, however, have some residual bladder dysfunction. There are rare cases of NMO, neuromyelitis spectrum's disease, which are antibody negative, can also be antibody positive, that there's in the setting of paraneoplastic syndromes and neurosarcoidosis. And then there's a large cohort. We don't really know what their underlying disease is. And kind of like one thought is, are there other antibodies which we have not really identified at this point? I'm talking now a little bit more, turning our attention towards treatment and prognosis. This is slide to highlight the severity and the poor recovery of these relapses. So you'll see that patients who present with transverse myelitis, roughly a sixth of patients will have complete recovery, while the rest may have some partial or not even any recovery. In the sense, in the setting of optic neuritis, is roughly a third of patients who may have full recovery, whereas then 2/3 not. How do we treat an acute episode? Our standard treatment would be high-dose IV steroids, 5 days given on consecutive days. And then if there's no recovery, moving on for plasmapheresis with 5 to 7 cycles. You see here one cohort or the outcomes, the long-term outcome data at the 1-year mark of recovery. If you treat with steroids alone, only a third of patients may have recovery back to their baseline neurological status 1 year after acute presentation. If you have treatment with steroids and plasmapheresis, that significantly increases to roughly 2/3 of patients. We'll see in the lower panel, you'll see that time really matters here. As illustrated here, these are the days of the delay of starting plasmapheresis, and in white is the portion of patients who have a recovery back to baseline neurological status, and within days you'll see that the recovery rate goes significantly down. You see similar data here presented slightly different in terms of then if there's incomplete recovery, to distinguish between those who have no recovery versus some partial recovery. So time really matters. And then given that the disability is so relapse dependent, obviously our mainstay of treatment is also how can we prevent that patients have relapses, in particular giving the high severity of developing a relapse in the next few years. What we have found is we have very effective drugs for MS, which are shown to reduce the risk of relapse in MS. The same drugs, several of the same drugs are actually associated with an increased risk of relapse in NMO. So we have to do a very different approach to prevent relapses here. And until recently, our mainstay were basically a collection of immunosuppressive agents, all of them primarily tested in small prospective trials with very low numbers of patients, or in retrospective case series. And you'll see at the same time that these drugs are associated with a significant percentage of breakthrough disease. The optimal agents seem to be rituximab when dosed appropriately. That was what we were doing until 2019, or all our treatment options until 2019. And here are some highlights from some conferences. 2019 was an exciting year in the world of NMO, because there were 4 trials which showed positive results on 3 different agents, lowering the relapse rate. And I will walk you through the different drugs, which by now are all FDA approved for NMO. And we'll have here in the right panel a schematic of our understanding of the immune processes involved, as well as where we may have target for acute or preventative therapies. So you have obviously an epitope, which then an aquaporin 4 epitope, which then triggers an immune response with help of Th17 T cells. Then we have the B cell stimulation, the production of antibodies, all of that happens in the serum or in the serology, and then you'll have the transitions of these antibodies into the CNS, specifically the astrocytic feed, where then there's IgG deposition and complement activation. So these are all potential targets, and our 3 drugs available have 3 different areas where they then target this cascades of immune processes. I'll walk you through with all 3 drugs in a kind of like overview fashion. Eculizumab is an antibody against the terminal C5 inhibitor, and it's given by infusions, initially weekly infusions and then maintenance every 2 weeks. Given its mechanism of action, it's very important that patients are getting meningococcus vaccination prior to initiation of treatment. On the right panel, you see the data of its pivotal trial, where there were 143 patients who are all antibody positive were treated. Patients were at baseline on had evidence of relapsing disease with at least 2 relapses in the last year or 3 relapses in the last 2 years. And you'll see that the group who were randomized to eculizumab had a significant reduction on the relapse rates. Basically the primary outcome was time to first relapse, and every little check mark here is one person, persons who have had a relapse. You'll see overall a relapse reduction by 94%. It is FDA approved only for antibody positive patients, and that dates back that the whole trial was only facilitated in patients who are antibody positive, given that there was some preclinical data that based on its mechanism of action, it appeared that aquaporin 4 negative patients did not have any will not have any treatment benefit. The second drug is satralizumab, an antibody against IL-6 receptor. This is given by subcutaneous injections and induction injections in the first months, several, I think 3, and then followed by maintenance injection every once a month, which patients can obviously do by themselves. There were 2 clinical trials or 2 pivotal trials. The first one is an add-on therapy to different immunosuppressant agents. The smaller cohort where you have 55 of this 83 patients were positive. They were trying to match the percentage of positivity in the general population or in the cohort of NMO patients. And again, primary endpoint time to first relapse. And in the add-on trial, you see that in those who are antibody positive, you see a reduction of relapse by 79%. A second trial tested the agent as monotherapy and have found a 74% reduction in antibody positive patients. Both trials did not show any treatment benefit in antibody negative patients. So it's approved for antibody positive patients only. We have to keep in mind that the number of antibody negative patients were obviously smaller, and that it may have been not entirely powered to show benefit from it because of the use of the placebo as well as the severity of the relapse. There are obviously some ethic considerations in terms of using placebo-controlled trials in this population. The third drug is inebilizumab, an anti-CD19 antibody, which is dosed with giving an induction therapy, 2 infusions 2 weeks apart, and then maintenance therapy every 6 months. Very similar dosing schedule to the rituximab and anti-CD20 antibody, and you will be quite familiar with. In the pivotal trial, there was a 3-to-1 randomization of active agent versus placebo with a larger cohort. The vast majority of patients were antibody positive, again, with the goal of recruiting roughly presentation of positive and negative patients in the cohort of NMOs patients. And in this trial, you see a 77 reduction of the relapse rate in positive patients. There's insufficient data in terms of the patients who were antibody negative. Overall, there are only 17 patients who were antibody negative within a 3-to-1 randomization. So there were only 4 patients negative in the placebo arm. That obviously gives us very different power, and you would need a way larger and longer trial where then you run into the ethic problems with that. So that is proof for antibody positive patients only, and the trial was actually prematurely halted in terms of the randomization phase of the trial for the significant treatment benefit, which was 73% relapse reduction in the total population. For those among you, to kind of just illustrate here the differences between the CD20 and CD19 expression on our B cells. CD19 includes plasmablasts and plasma cells, in contrast to the CD20 agents, or CD20 expression on immune cells, and then therefore being target of anti-CD19 or anti-CD20 treatment. There are some challenges and unanswered questions for sure. As I already alluded to, there are some difficulties with clinical trials, given how rare the condition is, which may be having a total cohort of around 8,000 patients in the United States, and the severity of the relapses. We clearly would love to know more about comparative efficacy and long-term safety of these agents, but again, that is challenging information to get from clinical trials in our traditional ways. Clearly, we have yet to learn the long-term safety of newer agents, specifically as antibody positive NMO patient we think will require lifelong immunosuppression. Among my patients, the oldest patient I have is in her mid-80s, and it's kind of like a challenging task as a clinician to kind of like feel, do I really have to treat this 85-year-old woman, which has a lot of other comorbidities with an immunosuppressive agent, such as during a pandemic. We also don't have good information on treatment algorithms or sequences of treatments, and yet to better understand and have treatment better understand the treatment options for patients who are antibody negative. And another challenge is money. And I'm pretty sure I'll talk to some like-minded clinicians who are running in the same problems, that drug prices are insane. And I'll the costs of these treatments are enormous, which have been those treatments which were recently FDA approved. This is by no means meant to be scientific. This is my own quick Google search for cost prices. As you all know, it's hard to get really good, reliable data on that. It's just for giving you an expression that these drugs are really, really, really expensive. And if you Google eculizumab and drug price or cost, you will get the first hits you get as why is this the most expensive drug in the United States or world's most expensive drug. Then so kind of like up to from 200,000 treatment costs per year. And that, for instance, with an anti-CD19 antibody, we will have now a generic anti-CD20 antibodies, which bring the cost down for those, balancing that with the cost of an anti-CD19 therapy. So for my didactic, I'm coming here to the end, and in summary, NMO is a CNS autoimmune mediated inflammatory disease with its core clinical features of the optic neuritis, the longitudinal transverse myelitis, and area postrema with quite impressive intractable hiccups or vomiting for prolonged times. We have a pathognomonic antibody against aquaporin 4 with high sensitivity, in particular high specificity. There's a high risk of relapse in those patients. There's a high risk of morbidity, mortality, even mortality with these relapses. And so aggressive, timely treatment for individual relapses is needed, but then also relapse prevention. We have 3 different highly effective FDA-approved treatments for NMO, but given certain challenges, including their costs, there will remain a role for our long-term known immunosuppressive agents such as rituximab. Oops, sorry, that was the wrong direction. So I brought some key articles for residents or other trainees here with a diagnostic criteria and some really well-written review articles to give you a flavor and go in more depth on this condition. And then I'll thank for the opportunity to talk to you guys all, and I want to introduce you briefly to our team at the MS Center. So we were one of the first clinical services which already back in 2012 were relocated to the Northwest campus, and we were the first UW-MC clinic there. On the higher level, you'll see our physicians, and we have grown. We have now 5 neurologists. We have a comprehensive care team. Otherwise, we'll have our 4th rehab psychologist joining us in June, and we'll have a vocational counselor. My slideshow is gone, but I hope you still can see me. I will then stop sharing. Do I see? Let me just see. You guys are still there, is that correct? Yeah, I'll stop sharing and start with the Q&A session.
Okay, so thank you, Dr. Wundes. I can see, it looks like a Q&A, a question just popped in, and I saw that Dr. Mustelin typed a chat in the chat box. I don't know if you saw that.
Okay. Is an overlap between NMO and lupus transverse myelitis? Yes, I would say there is, because with lupus, you also will find this longitudinal extensive transverse myelitis, which you also will find with sarcoidosis often. I had a challenging case where finally with a lot of persistence, we were able to identify this patient with neurosarcoidosis. But I know that similar clinical and MRI presentation can happen with lupus as well. Is the cell-based antibody testing now routine? I wish that would be true for everyone. That's definitely what MS providers or patients who are treating NMO are arguing for. That's what you will get when you're sending the test, however, at the UDAP. So that is a test which is sent out test at the Mayo Clinic. But if you are coming across a patient who comes from outside, it's very worthwhile to check whether a test was done and it maybe was repeating the test. How broad is the B cell response? In a single. I'm not sure that we know the answer for that right now. We'll have, I don't think that we have good data on T-cell focused therapies. There's in MS, we have one treatment, which we believe works primarily through T-cell mediated processes. And that is one of the agents which was shown to be associated with worsening of NMO. So I think with that experience, there has been not much research that I'm aware of T-cell mediated immunosuppressive agents. The most experience and long-term experience is definitely with rituximab, which often works really nicely if dosed appropriately. When you're making sure that patients are redosed at their when they have early signs of repopulations, then they seem to be a quite effective treatment.
Dr. Wundes, sorry to interrupt. It looks like Dr. Lee Nelson has asked for the ability to talk, so I'm going to upgrade her so she can ask her question. Dr. Nelson, you should be able to ask your question now. Okay, it says unmute. Can you hear me?
I can hear you.
Oh, I'm so sorry you can't see me. I'm smiling. What a great talk.
Thank you. It makes me smiling.
My question is, it looks like, if I recall correctly, you were saying this patient had a couple pregnancies and was considering getting pregnant again. And
yes,
I understand that this disease also, like multiple sclerosis, improves during pregnancy. My question is whether parity is either protective or a risk factor for developing this disease, having had a pregnancy or any aspect of reproductive history.
I don't think that we have good data on that. And you're right that there is some data in terms of acute pregnancy, having a different course during acute pregnancy. I have there's a publication which described that in general during pregnancy, the disease may be more silent, but I can tell you from personal experience, I've also seen the exact opposite of that. I followed a patient, a young patient who had the most horrible relapses throughout her pregnancy. In the end, was one of the reasons why then there was early delivery at around week 32 or so, because we could just not control her. She had one relapse after the other throughout her pregnancy. So there are definitely exceptions to that general rule. But I am not aware of any data in terms of parity being a risk factor.
Okay, thank you.
Thank you for this question. Anyone else who wants to ask a question in person? Otherwise, I'll see if I can read the next one. Do antibody levels correlate with the disease activity? Do you follow antibody levels? There's some data that when patients are being treated with an immunosuppressant, that the antibody levels will go down, but we are not really including that into our treatment algorithm. So it's not that we are targeting a certain antibody test. Once you have the established diagnosis, I really don't see any value in retesting patients. So the treatment effect itself of an agent is not reflected by the antibody level. I'm scrolling down to the next question. Yes, so it's about stem cell transplantation. The next question. We have more experience with MS and stem cell transplantation. And that's a quite potent treatment option for patients with highly active, non-responsive MS, which is not responsive to our standard treatments. We do have also NMO experience with NMO and stem cell transplantation, even here in Seattle. So there's a collaboration from our team, Fred Hatch and Swedish, which is having ongoing trials already of more than 10-15 years in that area. We ourselves have transplanted, I believe, 5 cases, so that's a small number. There are a few publications out of other small case series as well, and in general is felt to be effective in these case series or small single case reports. But it's also important that treatment is initiated rapidly. I have a very sad course of somebody where kind of like that we ran consistently into insurance barriers with that, and while it was in the end approved and facilitated, he had lost a lot of function in a young teenager. And so that is seemed to be an effective approach in those who are non-responsive to standard treatment, but it's limited to case series and small case series. Okay, any additional question? I see in the chat box there may be 2. We engineered to work through ADC. Eliminated. Thanks for that comment. Not sure what to say about it. And then the okay, Dr. Nielsen already said this. Thomas, if you want to elaborate on your comment, I'm happy to hear about that.
Let me see if I can give Dr. Mustelin.
Yeah, or anyone else who may have a question.
So Dr. Mustelin, if you wanted to share your comment that you had typed into the chat, you should be able to now.
Can you hear me now?
Yes. You're a little quiet.
I just wanted to point out that the way that the CD19 antibody inebilizumab works is by activating ADCC. So all CD19 positive cells are killed off. And so that's similar to how rituximab works, except that CD19 is expressed, as you showed, a little bit later into plasma cell differentiation, such that this antibody will eliminate at least early plasmablasts, which make the aquaporin 4 autoantibody. So the mechanism is slightly different from rituximab.
Yes, it is. And I did not mean to say it's the same as CD20. Or when I was talking about costs, it's definitely a different, slightly different a mechanism of action. But then we're all, so I think that came up and is probably geared toward the comment on the slide of the costs, that is kind of like still we are dealing with all these explosive drug costs. And if somebody, for instance, is stable on a CD20 antibody, is it justified to escalate treatment in that moment towards a CD19 therapy, even though the impressive efficacy data in the clinical trial?
Yeah, so that's of course a very good point. I'm very much aware of drug prices because I actually worked at MedImmune when inebilizumab was made in my group. And I do understand why it's so expensive. And simply a mathematical formula that comes from how few patients there are and the cost of developing it. But that's, a different topic to discuss at some point.
Yes, and I'm pretty sure development of drugs is a costly endeavor, and I'm definitely not questioning that part either. Yeah.
So Dr. Wundes, it looks like there is one last question in the chat, and then after that, we probably will have to wrap up before our next session.
Yes, okay.
Or I'm sorry, it's in the Q&A box.
Yes. I am not aware. I am actually not aware with this agent either. And that does not mean there are no clinical trials that I'm not fully aware of. But I cannot contribute to this question. Sorry about that.
Okay, well, I just want to say thank you so much for joining us, Dr. Wundes.
Thank you so much.
Yeah, that wraps up our session. Thanks, everyone.
Thank you, everyone, for attending. You have a great day. Bye-bye.